So what if they don't improve? Because the more FODMAP information that gets out there, the more often people have tried it by they come to see us. And so we have to think about what else could be happening with these symptoms. So we would certainly sometimes look at probiotics. The tricky thing about probiotics is that it's in quite its infancy at the moment, where we don't know what bacteria is in that person's digestive tract, therefore which one we would recommend to supplement. So it's a bit of a guessing game based on the research and which probiotics have the most research behind them. So we do sometimes use those, but we would only use those for 6 weeks, and if the person doesn't have any benefits after 6 weeks, we just completely stop. So that's the length of time we need to establish if it's going to work. Fibre supplements, do we use Metamucil, Consol D, Normal Col in clinic, those types of things? So we would look at psyllium husk as something to try and both soften a firm bowel motion and then also draw together a loose bowel motion to try and create a better consistency. Peppermint oil capsules are great. We get really good results with those. So that's either Colpomin or Mintec. And the way that the peppermint oil works is it's a smooth muscle relaxant. So the smooth muscle helps to reduce the symptoms of bloating, wind and discomfort. Doesn't help with bowel motions, but it certainly helps with all those other symptoms. And that can still be from non-food related symptoms. So it can be from anxiety or stress, because it's the same type of tension that's going on inside the gut. So we certainly use those.
When's the best time to advise someone to take it?
Yeah, so I would advise that if the dietary side didn't work, or if I wasn't going to try it.
What time of the day?
Oh, sorry, right, it's 30 minutes before eating. Yeah. So it states that on the packet, that you're supposed to take it 30 minutes before food, because if you try to take it with food, the enteric coat breaks down while it's in the gut, and then you start burping up very strong, sharp peppermint. Iberogast is something we've just started recommending in clinic, is here. It's got some good clinical research behind it now. So this is a herbal supplement, not something I would normally ever recommend, but the research is robust enough now that we can start recommending it. And this is something you just take 1 ml with food, and it's reported to help with all symptoms. And I have had some people able to stop colifac while on this. So it's certainly it has an effect. We always look at stress management, as I mentioned at the beginning. Sometimes medication, whether it's amitriptyline for nerve pain or stool bulkers or things like that, we would ask them to go back to the doctor for a medication review. And then we look at other chemicals, so we get someone to do a food diary for us, try and pick out the things that somebody might be reacting to. So if you have somebody who's reacting to strong things like citrus and tomato-based things and herbs and spices and alcohol and caffeine, you might suspect a food chemical sensitivity, particularly if they're a bit nauseated, a bit headachy, a bit rashy, itchy. That's certainly something that you might look for. Probiotic is actually adding bacteria into your digestive tract, and that's fermented foods as well, so things like kombucha and kefir and sauerkraut and things like that. So that's a probiotic. And then a prebiotic is foods that feed your bacteria. So they are the fuel for it, whereas the probiotic adds bacteria. So they're quite different, but yeah, they sound so similar, don't they? So the types of foods that are prebiotics are our FODMAPs. They are all prebiotics, which is why you get symptoms, but also anything with fibre really is really good. And then polyphenols are excellent as well, like olive oils and dark chocolate and things like that. Yeah. Doesn't it? And a glass of wine, obviously there's lots of polyphenols in that. Yep. So in terms of whether you have refrigerated or not, so that means that they're not shelf stable. When I've contacted companies about it, they'll say, well, if it's 30 degrees, you can keep them out of the fridge for 4 days, or if it's 20 degrees, you can keep them out of the fridge for a week. It just reduces the potency if you keep them out for too long. But certainly there are some that have got better evidence behind them than others. So we always recommend to start off with the Ethical Nutrients IBS Support. The Ethical Nutrients IBS Support, it's a single strain and it's been researched around IBS management, so that's the one we try first. So with the diverticular disease, we usually treat the IBS symptoms like we've just discussed with IBS, because if their symptoms persist past the acute phase, usually they're diagnosed with a functional issue around that as well. So we would have the same dietary management. There is no evidence to suggest we need to avoid any kind of pip seed stalks. A lot of people are very hyper-vigilant about that, and they're sieving their tomatoes, and they're getting very worked up about it, but the evidence simply isn't there. Obviously, we still reduce residue when people are inflamed, and we have a structured reintroduction when people start adding fibre back in again, similar to if they've had bowel surgery or things like that, when we're trying to just add foods back in again. So we start with the soft, smooth fibres, the soluble fibres, and then we would leave the rough, harsh, insoluble, bitty fibres to later. But this is often a confidence building thing. People are very scared to introduce foods again in case they exacerbate things. So it's just telling people that actually you're going to have better outcomes if you add more fibre in. So just moving on to celiac disease. We've got obviously the gluten-free diet is a mainstay of treatment, and we have to correct nutritional deficiencies as well if they've got quite low, which we would then gets repeat blood tests to make sure these things are getting corrected, because we can ask somebody what their compliance is to the gluten-free diet, but if their levels aren't improving, that might indicate that they're not as compliant as they might be. They're saying they are, or that they just require extra support to boost their levels back up again. So gluten, we already discussed in great detail. It's the storage protein in wheat, rye and barley, and I've got kind of oats because of all the stuff we've just talked about, how the fact that it's due to the contamination, and you can buy contamination-free oats, which are more expensive. You can get them online, and there's lots of different discussions around oats, but the area we are most cautious about is if there's peak areas of growth. So in children, if they've had failure to thrive, we're very hesitant to add oats in at that stage. Or if someone is having fertility issues and we found they have celiac disease, we're very cautious around certain populations around that. But when I was at the university as a clinical tutor, we had a student do a lit review on people with celiac disease adding oats, and there was a very small, I think it was about 5% of people were having reactions, and all of them were reacting. All of them were having symptoms, so that was quite a good indication around that. Now, I don't know if you noticed, but when people don't have symptoms, the motivation can be quite hard. So if they are diagnosed due to iron deficiency and hypothyroidism, that motivation to avoid gluten when their friends are going out for kebabs or their favourite food in the world is dumplings, it's really hard. So it's that empathy and that understanding with the person and making them understand why it is important to avoid it. And you know, certainly I've had people ask me, can I just shift onto the gluten-free diet? Is that okay? And you just have to have an open and honest conversation about if that's what you can manage, then that's better than trying to rush into it and then just feel completely overwhelmed by it. So that's something. Would you kind of allow people to kind of gradually move on to it if they needed to? Yeah. I have one woman I'm working with who her favourite food in the world is dumplings. Well, I remember that. And so whenever she goes out drinking with her friends, she just can't help herself. She has it all the time. So she does that about once a month. And she's just said to me that I just can't do any less than that. And I said, okay, well, I can't, you know, that's going to be her best management of that. So what is gluten-free? So the FSAN standard, which New Zealand, Australia follow, is less than 3 parts per million no detectable gluten. That's reduced over the years. So it used to be 100, 50, 20, now it's 3. And this is as our detection methods become more exquisite. The detection goes down. And obviously that drives up the costs of gluten-free foods because they have to meet a certain level of standard. So the international Coeliac standard, which is the rest of the world, they use 20 parts per million, and so there are some foods in our food supply that would be deemed gluten-free if we use the Coeliac standard. So there is discussion about whether we move to the Coeliac standard, but that still hasn't come to fruition just yet. But this is why you will see confusion around oats being called gluten-free, because they are from countries that use the Coeliac standard. So how do people choose gluten-free food? So there are 3 different ways people can choose gluten-free products. The first one is to understand that a food is naturally gluten-free. So does anyone know any foods that just naturally don't have gluten in them? Vegetables, rice, fruit, fish, meat, yes. Eggs, yes, good old egg. So it's all these foods that naturally are in their pure state, that don't have any gluten in them. So these are foods that would be the mainstay of people's diets. And then we've got people's ability to label read. So this is a really important tool to teach people, because not all foods will say that they're gluten-free, but they are gluten-free. And that's the importance with that, is that as soon as something puts gluten-free on it, their price tag goes up. So if someone is able to go, actually these foods are also gluten-free, but they're not in the gluten-free section, that really helps their ability to keep costs low. Luckily with gluten, that's an allergy claim criteria in New Zealand, so that has to be listed on the ingredient list if it's present. The third and really easy way is it says gluten-free stamped on the front of it. So this is where we've got the gluten-free aisle. This is Schaefer's, just over there. And it's huge. The variety of foods there now is very impressive, and all different types, packet sauces, breadcrumbs, crackers, biscuits, cheese sauces, canned spaghetti, you name it, they've pretty much thought of it. So those are the three different ways that we teach people in clinic about how to choose it. So this is an example of label reading. So oak baked beans say nothing about gluten on the front or on the back. But if you look at the ingredient list, to the discerning eye, this is all gluten-free, because they're using maize flour and maize thickener. Again, they don't mention anything about we are gluten-free or anything, but they are naturally gluten-free. Whereas if you look at baked beans, they have wheat flour. So for somebody to be able to label read, this is where it shows it's very important to be able to pick those things out. And again, the Coeliac Society have books on thickeners and numbers about which ones are gluten-free and which ones aren't, and they're really useful to have. So how some people get caught out is that they will see the word wheat on the ingredient list and automatically assume it must have gluten in it. But if these products are derived from wheat, they're so processed and so devoid of any possible protein, which is what gluten is, that they are now gluten-free. So there are quite a lot of lollies, not necessarily that's what we're pushing people to have, but it gives options. There are lollies that use glucose syrup derived from wheat, and so when somebody sees wheat, they automatically think that, but anything that has these products derived from wheat are fine, which is really helpful. So of interest, the may contain traces of is a voluntary system. So we tell people not to get too caught up with that, and that again, that differs depending on your opinion of which organisation you speak to, but aware of the belief that if you're going to eat a food a lot, it's something that you want to be part of your everyday diet, and it says may contain traces of or made on the same line as, you should contact the company and ask how likely is it there's contamination. Whereas if it's a food you just have occasionally, we tell people not to worry. Is that something along the same lines? That's what our dietitian who has celiac disease does.
Yeah. And I think a lot of people with celiac disease actually have their own sort of threshold.
They do.
That would sort of, and so my threshold is that if it may contain traces, then if it's a small amount, then I'll eat it. But if it says made on the same production line as,
yes, that's
then I
different.
tend to not want to risk it.
Yes.
Although, when you talk to some of the companies, they'll say, well, we make our gluten-free products first and we've cleaned the lines and all
Yes.
this. But that's my internal kind of way of doing it. And different people will have different thresholds.
Definitely, and it depends on the person's anxiety around the food. Contacting the company can be a really good way of them going, actually, they just put that on there because, just in case. Yeah. So what's really interesting is that the gluten-free diet has boomed, which the benefit is that there are way more gluten-free products, but the negative side is that people are assuming it's a healthy diet. They're assuming that if I don't eat gluten, I must be healthier, but in fact the complete opposite is true. So a gluten-free diet is a much higher glycemic index diet. It's naturally lower in fibre and iron and thiamine, sometimes folate, particularly for those who require more folate, sometimes thiamine, particularly if you're also vegetarian. So we are often having to, every person that comes through our door that is either gluten-free from their own preference or they have celiac disease, we always educate about actually how do we make this diet balanced, because we're having to include foods, and this is where oats are particularly helpful, because if someone has type 1 diabetes, which often comes together, adding oats in, which are very low GI, is a really precious source of soluble low GI carbohydrates for the diet. So it is something that's very beneficial. So with the iron, about 40% of our iron intake comes from whole grains, so it's nearly half of our iron, and so people assume I'm eating red meat so I must be fine, but if you get 4 milligrams of iron from a steak and you need 18 a day, you can see where you can't assume that that's going to be enough. So there's a lot of education about how do we make sure you get enough fibre, how do you make sure your blood sugars are looked after, how do you make sure you get enough iron, those types of things. So the assumption that it's a healthy diet really needs to be addressed, particularly if people are doing it unnecessarily. So the usual ways that gluten is ingested in someone with celiac disease is either poor label reading, cross-contamination, or occasionally when they have it on purpose. So the cross-contamination is something that gets a lot of people, because they might go somewhere and the people say, oh, this is gluten-free, but it's gluten-free ingredients. It doesn't mean it was made in a gluten-free environment. So they might have used a chopping board and a knife that was used to cut up bread or crumb something. So it's that gluten-free contamination that really gets people in. The occasional gluten-free contamination might not actually cause problem. It's a compounding effect of it as well. But if we're talking about one crumb is enough to actually set people off. You can see where toasters and sieves, people forget that if they've used a sieve to drain pasta, it's all the little mesh can trap little bits of pasta in it. So we're having to be very careful with it. And the way I describe to people about gluten is think of it like raw chicken, because if raw chicken, we have very good safety standards around that in terms of hot soapy water, washing down the knives, the boards. If it's a similar kind of strategy, you'll be fine. So I sometimes go into cafes and restaurants to educate them about how to deal with the difference. And so first of all, people with celiac disease, we always tell them to tell the staff that I have celiac disease. It's not just gluten-free, because that's a very different management in the kitchen, very different management. So you'll get a cafe that I work with, they use tin foil and they put it under the grill to cook the bread, as opposed to putting it in the toaster and putting gluten-free toast in the toaster. So it starts from the person with celiac disease actually saying, I have celiac disease, or even calling ahead of time, can you cater to someone with celiac disease? But the kitchens must know, and the staff need to ask as well. So I tell the staff, if someone says they're gluten-free, say, do you have celiac disease? So all levels need to understand, this kitchen staff, the wait staff, and the person who has it. Yeah, comes all different levels. Yeah. So just moving on then to non-celiac gluten sensitivity. So some people are very sensitive, and I'm surprised they don't have celiac disease, and I'm even thinking now that maybe they just weren't tested enough times, because they will be very sick for multiple days with just a small amount of contamination. So I think there's probably a spectrum here, where there's some people who are just a wee bit sensitive, right through to those people who are highly sensitive. So we always tailor, and this is the reason why having celiac disease is so important to diagnose, because if it's a non-celiac gluten sensitivity, we will encourage somebody to find their threshold, to find out how sensitive they are. Some people have a black and white view around gluten, which needs to be addressed, because they'll have that feeling of, I need to be completely 100%, and they'll be using tamari instead of soy sauce, and very high level avoidance. And just, I mentioned on this briefly before, just touching on this mental health that comes along with such strict avoidance, and that can really cause issues with orthorexia, obsessions with having to have the right types of foods. It can cause anxiety when you go out around whether I can get something that's gluten-free. It can cause social isolation, because they don't want to spend time with friends and family eating in case they get contaminated. So there's very real issues around that, not just physical, that come around food exclusions. I'm working with one woman at the moment who's been vegan for many years, and she's moving out of her eating disorder in a really lovely way, and she's just recently become what we've called a flexitarian. So she's then flexing herself, and her ability to move into the next stage of eating disorder recovery is amazing, because she's realised that she just was so isolated and so having to think about B12 and protein and having to really think about foods in such a methodical way that was very reminiscent of her disorder. So yeah, we're always having to just ask people if be careful of that for sure. Monash did a study on looking at FODMAPs versus gluten, and they confirmed the very true existence of this condition. And the biggest symptoms that they noticed was the mood changes and the brain fog. Not a lot of GI symptoms, some, but really this feeling of feeling down or melancholy or frustrated, and it was very interesting. It was double blind, and very, very interesting results. So just lastly, inflammatory bowel disease. So I could talk a whole nother hour on this topic, so I've just really tried to condense it into a few short slides. So the biggest issue with IBD is undernutrition, malabsorption, and the resulting complications with that. So we're looking at iron, B12, depending on, especially on the site of disease activity, folate, calcium. Often people with IBD will not be eating dairy products because they don't think it's tolerated, or they might be on multiple courses of prednisone causing bone density issues, which all compound into an issue with bone density and calcium. And often total calories are not consumed due to fear around eating or feeling sick, or increased losses from diarrhea or vomiting. So there's a lot of nutritional issues going on with IBD when it's not well managed. So this is where nutrition assessment is vital. We will be looking at people's food intake in quite detail. We put it into our system, which it tells us what percentage of calcium, iron, thiamine, all those types of things that come out, to make sure people are getting everything that they need. We do look at vitamin D status and whether supplementation is needed. That's something that's quite valid, and also omega-3, with it being more of an anti-inflammatory type oil in the body. So we're trying to get people to have more fish or walnuts or flax seeds and things like that. So looking at the omega-3 states too. So there is actually a role, and I'm not sure if many people have had experience around this, for exclusive enteral nutrition with IBD. So this is usually used in a polymetric formula. Sometimes it's but this is typically what's used, and the evidence is very strong in children and adolescents, particularly newly diagnosed, and the outcomes are just as good, if not better, than steroids. And obviously you have that wonderful steroid sparing effect in childhood, which we're really trying to avoid high doses at that time, or an adjunct therapy as adults. So the research isn't as robust in adults, but certainly elimination or is for an elemental style is more indicated in adults. So elemental 028 is often indicated in that case, especially if someone's not responding to medications or other types of interventions, and we're kind of thinking, what else can we do? I've got one child at the moment who's on exclusive enteral nutrition for her newly diagnosed Crohn's disease management, and she's doing really well. It is really hard for them when they can't eat with their friends, so she's having to drink 7 Fortisips a day, and that's basically all she has in the day. But there is, interestingly, partial enteral nutrition, which is something that's fairly new as a alternative to complete enteral nutrition. So it's where we have 50% of our calories coming just from food, whatever you like. There are some protocols of which foods those should be, depending on which study you look at. And then we have 50% enteral nutrition, and that has really good health outcomes as well, even if you look at a 2-year follow-up period. So that's certainly something where we're trying to go, maybe we should explore that area a little bit more. And the reason why this works, the thoughts are varied. It could be to do with changes to the gut microbiota, it could be to do with bowel rest, it could be to do with nutrition. There's all sorts of theories out there. So just a note about fibre. So do you have many client or patients with inflammatory bowel disease? A few, yes. And what's their opinion about fibre? they're usually trying to avoid it, aren't they? Typically it's something that people are quite scared of because of the association with pain, the association with diarrhea, and the very real recommendation to avoid fibre when you're having an acute flare, because obviously you want to rest the bowel, it's a bit more uncomfortable having all that fibre going down. But avoidance of fibre, interestingly, is actually associated with a greater risk of flare. So what we're really trying to advocate for people is that as soon as you're starting to feel well, we need to get that fibre back in again, because there is a very real difference between whether someone has adequate fibre or not. The ulcerative colitis, it's not so profound, but certainly with fibre supplementation, there is some benefit in that side as well. As I said, we still do recommend low fibre when someone is having a flare, but really important that we're getting fibre back into their diet as they're starting to feel better again, because I have people years and years and years on low fibre diets and they're just making things worse, they're just exacerbating things for them. So again, we would introduce fibre back in again gradually. So instead of going from white bread to grainy bread, we'd go white bread, wholemeal bread, grainy bread. So I've got somebody at the moment where we're slowly reintroducing things. So we're doing canned fruit and then cooked fruit and then raw fruit. So it's a gradual reintroductions of foods back in again. So as I kind of alluded to earlier, with IBD and IBS often happening together, we have to manage the functional bowel symptoms through the same dietary means as we talked on earlier on. Similar strategies to IBS, so we could try the FODMAP diet, we could try meditation, all sorts of things like that would be the same as with IBS. So I've just got my last two slides on the gut microbiome. Again, I could talk about this for ages. It's one of my favourite areas of nutrition at the moment, or of gut health. So there is great interest in the role of gut microbiota in relation to the gastrointestinal disorders, and I belong to a few research websites where they send all the published research from around the world when it comes to the gut microbiome, and they're just looking at all sorts of things from fecal transplants to dietary manipulation to meditation. They're looking at so many different things when it comes to IBD and other gut health things. So what is clear across all studies is that there is less diversity, and remember we talked about diversity being the most important thing when it comes to gut health. There is less diversity in IBD and in IBS, but we're unsure of cause and effect. So there was a study published about 4 or 5 years ago where they looked at, they took samples at inflammatory sites in newly diagnosed Crohn's, and they saw that there were much higher inflammatory bacteria in those sites, but again, is that cause or effect? So that's something that we're having to really follow that line of thinking. But I just wanted to talk to you about some of the factors that influence our gut health and which ones are going to help increase diversity of bacteria and which ones aren't. So you might be armed with a few tools that you can talk about in clinic of these are the foods that might be helpful for your gut, and these are the things that you might want to reduce just to help things out. Because sometimes we talk to people about gut health and that's all we'll do. We won't actually do an elimination style diet. We'll actually just talk about gut health and how to rebalance things a bit more. So bacteria do not like processed foods. Now I'm talking more kind of highly processed foods, because you could argue that milk is a processed food, but we're talking higher processed foods that have got a lot of thickeners, emulsifiers, colorants, these types of additives to it. And we are seeing research in rodent studies that are showing that some of these additives are having a very detrimental effect from an inflammatory bowel disease stage. So we're really looking a bit more into that. Too much alcohol and highly sugared drinks are not a great idea. And interestingly, sleep and stress have quite an impact on diversity of bacteria. So I will see people where their symptoms will be much higher if they haven't slept well for a few days in a row, or if they're obviously stressed at work or at home or family life. Limited variety in the diet. So if you think about what the average person eats, you probably don't ask as much as I do, but people typically have 1 or 2 fruit that they eat. They might have 2 or 3 vegetables that they eat, and this is kind of on repeat and rotation. So it's carrot and broccoli every night, every day. an apple and pear every day. Yeah, so this is how we get stuck on this repeat cycle, and we're creatures of habit, right? But there's that limited variety that's really getting us into trouble, because your bacteria will feed off all the different elements of the different fruits and vegetables and nuts and whole grains. So we are trying to promote people just to get more variety, and it's such an unsexy message, but it's something that we're really trying to push at, trying to just cause basic general health. And this is from mental health perspective as well, because the research studies are showing that Mediterranean style diets and higher variety diets are also helping with depression, postnatal depression, anxiety, all sorts of mental health as well. And antibiotics, which obviously we can't help at times, but it's also being selective about when it's helpful. And yeah. Whereas supporting that gut microbiome, the things that we can do is add fermented foods, which we were talking about before, as a natural probiotic. Now, sometimes all the bacteria are dead by the time they get to your gut, but the dead bacteria can still act as signaling molecules, which can still have an overall beneficial effect inside there. Then we have polyphenols, which we discussed before, which are found in brightly coloured fruits and vegetables, extra virgin olive oil, the dark chocolate, the red wine. It comes in lots of different healthy natural foods. And then we've got prebiotics. So has anyone heard of MACs? Microbiota accessible carbohydrates. Now, I only heard about this 3 months ago. So this is the new way that we're looking at fibre when it comes to gut health. So these are carbohydrates that your bacteria can actually access. There's no point eating fibre that they don't actually have the ability to utilise. So resistant starch, is that a term familiar to many? So resistant starch is the third main fibre that's found in our diet. So we've got soluble fibre, we've got insoluble fibre, and then we've got resistant starch. Now, resistant starch happens to be found in potatoes and rice that have been cooked and then cooled down. Now, they're very high in resistant starch then, even if you reheat them. So one of the really interesting observations that we've had is that why do some countries that don't have particularly high fibre levels have very good gut health? And what we've realised is that they tend to eat a lot of resistant starch. So they'll cook up a whole lot of rice in the morning, and then they'll just reheat it throughout the day as they eat it. So we've noticed that these countries that don't have a lot of fibre per se, as what we would think, have a lot more resistant starch, cooking up tubers, cooling them down, and then eating them throughout the day or the week. So the resistant starch comes from this cooling down of these two grains, potato and rice in particular, and as I said, even if it's reheated. And it's also found in our green bananas, not that that's a massive part of our diet. And then the MACs are also found in soluble fibre. So soluble fibre is found in barley and oats and fruits and vegetables, particularly in the flesh, not so much the skin, that's the insoluble fibre. And then also the legume group, which again is a reason why legumes are so important. They're very high in soluble fibre, and they're interestingly high in everything that is missing in a gluten-free diet. So they're high in fibre, iron, folate, all the things that go down in a gluten-free diet. So I'm always recommending more legumes. So these are the kind of small dietary changes that we can recommend that can make a big difference. I had a 12-year-old in my clinic last year, and he was suffering from quite bad constipation, and he went overseas with his family. I think it was to China or Vietnam, somewhere around there, and his constipation was a lot better, and the only thing that they noticed was that he was having a lot more rice over there, and not as much fibre, but he was having a lot more rice, which obviously is reheated in each of those places he was visiting. So I kind of thought, okay, well maybe it's this more resistant starch. So his mother started giving him rice every day for lunch that she had cooled and reheated, and his constipation was much improved. So it really showed to me that sometimes people really need a lot more of those MACs in their diet. And what happens is that the insoluble fibre, which are found in our grains and our seeds and our skins, what they do is they carry the resistant starch down to the large intestines and right through down to the rectum, where it's really important that our bacteria are feeding there, because this is a high risk area. So all the different fibres work together to either feed the bacteria or to carry the fibres that are important for the bacteria. So broad beans are very high in FODMAPs as well, so sometimes they're problematic, but the most well tolerated, so if we did notice someone had issues, we always recommend edamame beans, the soya beans. They're very low in FODMAP. Lentils are lower in FODMAPs, and chickpeas as well, but to portion sizes, so half a cup of lentils is low FODMAP and quarter of a cup of chickpeas is low FODMAP. So we start off with those to see how tolerated they are, and we kind of build up from there.
What about frozen peas?
So peas don't have the same properties as these, unfortunately. Yeah, no, but they're still nutritious, but yeah, no, they don't have the same properties. But interestingly, again, because FODMAPs are water soluble, if you were to get, so canned legumes are always going to be better tolerated because they're soaked. But if you were to drain those and then soak them in fresh water overnight, you're going to lower the FODMAP content even more. So for those who are vegetarian, vegan, or I'm trying to get more resistant starch, and I will use that method as well. Yeah, good question. Yep. Okay, so you've done well listening to me for that long. Any questions?
Sarah, if you were doing a FODMAPs introduction with somebody, how many sessions would you expect to be seeing them?
So I see every person 3 times. So they're beginning, and then 4-6 weeks later, and then maybe 8 weeks after that once they've done all their reintroductions. Yeah.